So I'm going to go ahead and turn it over to Dr. Karen Wendell.
Thank you, Victoria. So welcome everyone. In response to the evolving COVID-19 pandemic, we have launched this bi-weekly virtual learning community for the Mountain Plains to address COVID-19 management issues in our region. We welcome you all to session 6 today, and as always, invite you to forward the registration link to other colleagues you think would be interested in attending. Today, our speakers will be covering transmission precaution guidelines and rationale behind them. Remember, our topics will change every session, so please come back for continued learning opportunities. You're welcome to suggest future topics, comments, and opportunities to better serve this group. You can do this with your evaluation or by sending Victoria or Carolyn an email or chat in the chat box. As our presenters speak, we strongly encourage you to enter questions about the presentation into the chat box for us to address during the Q&A session at the end of the presentation. Before we get started, we want to acknowledge this is a joint collaboration between the National Emerging Special Pathogens Training and Education Center, NETEC, Denver Health, Denver Prevention Training Center, Robert Wood Johnson Foundation, and Project ECHO. My name is Karen Wendell, and I'm one of your facilitators. I'm an infectious disease physician working at Denver Public Health. Today's agenda includes a tech check with Victoria, as always, and 2 short presentations followed by discussion with question and answers. Victoria, take it away.
Great, thank you, Karen. So as you all know by now with Zoom, your mute or unmute button is going to be down in your lower left. It's either going to say mute or unmute, depending if you are muted or not. Next to that is that button I'll tell you all to push every single time, which is start video. So again, we love having people on video. It makes us much more interactive, not only for us, but for our presenters and our panelists for today. So if you wouldn't mind, please hit start video for us. A couple down, you're going to see the chat function. If you can go ahead and put in where you're calling in from. So I'll go ahead and put my location. We'd love for everyone to do that. So again, our presenters can see where everyone is calling in from around our region. You also have a reaction button. You can go ahead and give a thumbs up or a clapping if you want to kind of let everyone know you're agreeing with them. You can also just do the good old normal, like in the actual air. We can see that, so that also helps when you're on camera. But I will also post in the chat where our resources and materials are always kept for follow-up after the session. But with that, I'll turn it back over to Karen.
Okay, thank you. It's my pleasure to introduce Adriana Weinberg, who's a professor in the Department of Pediatrics and the Director of Molecular and Virology Clinical Laboratories at the University of Colorado, Denver Anschutz Medical Campus. She will discuss SARS-CoV PCR versus culture findings and implications. Adriana.
Thank you, Karen. So can I share my screen, Victoria, Karen? Yeah, can you see it now? I hope so.
Yes.
Yeah. Yes, we can.
So I want to thank Karen and Sarah for the opportunity of talking with you this morning. So as Karen mentioned, I'm going to focus on advantages of nucleic acid detection and how it compares with culture methods. So this is my title, Detection of SARS-CoV-2 in Respiratory Specimens. So since this audience knows very well what I'm talking about, I'll go straight into the meat of the discussion by listing the methods of detection of the virus in a respiratory sample. So the gold standard is nucleic acid amplification. The most commonly used method is PCR, but there are other methods that can also amplify nucleic acids. But at this point, the PCR is gold standard for sensitivity and specificity for diagnostic purposes. Next comes antigen detection, which has the advantage of being faster and cheaper and can be done at point of care. It's a low complexity test, but the sensitivity is only 80%. So specificity is pretty good compared with PCR. And then finally, the viral culture is not used for diagnosis, and this asterisk is here to remind me to tell you why. First of all, it requires BSL-3. It's very labor intensive and cumbersome. And the turnaround time is really not conducive for rapid diagnosis. So in addition, the viral culture is much less sensitive, and the only claim to fame for viral culture is that it may indicate infectiousness. And I want to emphasize that it may, because what happens in the tissue is different with what happens in the host. But it's the closest. So what are the biological factors that affect the diagnosis characteristics of these tests? So first of all, let's start with the ability of detect the virus in the specimen. Of course, the first thing is the amount of virus. The more virus there is in the specimen, the easier it's going to be to detect this virus. But in addition to that, there are other things to take into consideration, like the type of specimen. And when it comes to respiratory specimens, for example, lower tract respiratory specimens seem to have more virus, particularly later in the disease, than upper respiratory tract specimens. The quality of the specimen, I cannot emphasize enough how important it is to collect the specimen properly in order to get a trustworthy result. And then comes the time after infection. We all know that it's easier to detect the virus earlier after initiation of symptoms than later. And the severity of infection, with people who have severe disease staying positive for longer periods of time. Now, where do the false positive results come from? So there is a level of cross-reactivity, both in PCR and a little bit more in antigen detection. And that's due to non-specific binding of the primers or the antibodies that are used to detect the antigen. And for PCR, actually, the most common source of false positive results is contamination. So nothing is 100%, but PCR is as close as it can get to 100%. And I'm gonna continue on the theme of the amount of virus, because that's what's basically that's caught the attention in recent months since Fauci came out and said that we should use crossing thresholds to declare people contagious or not. And I want to explain to you why this is not exactly the case. So what is the relationship of the test result with the amount of virus in the respiratory specimens? I'd like to start by underscoring that all the diagnostic tests currently approved by the FDA are qualitative. What that means is that there is no direct relationship between the signal that's picked up by the test and the amount of virus in the specimen. Having said that, there is every test that's been approved by the FDA has a limit of detection. So the limit of detection indicates a minimum amount of targets, or the minimum amount of virus that's necessary to detect its presence in the specimen. For PCR, this varies from 180 to 300,000 RNA copies per ml. So you can, just from here, you can understand why there is a big variability, and not every PCR is made equal, or not all PCRs are made equal. For antigen detection, the bar is even higher. So in order to have a positive test, you need approximately 7 million, the equivalent of 7 million RNA copies per ml. And that's using the BEI strain, which seems to be pretty generous, amplifies pretty well. So you can see here how at least one order of magnitude more virus for a positive antigen detection test. And finally, the viral culture. To get a positive result, you need the equivalent of 200,000 RNA copies per inoculum. And depending on the methodologies, this generally translates at 2 million copies, RNA copies per ml. There's a typo here. Okay, so now let's move on. So we saw what determines the ability to pick up the virus, and now let's talk a little bit about the infectivity of the respiratory specimen. So again, the most important thing is the amount of virus. The more virus you have, the more likely it is to get for the specimens to transmit the infection. However, there are other important factors that have to be taken into consideration, and if we have time, we can discuss why. But the time after initiation of infection is very important. So in symptomatic individuals without immune defects, and I underscore without immune defects, when you go to immune compromised hosts, all bets are off. The median duration of replication competent viral shedding, so replication competent means a virus that's able to create an infection, is 4 days after initiation of symptoms. And the maximum duration in multiple studies has been 8 to 9 days. This is also confirmed by epidemiologic studies that not only show that the risk of transmission peaks during the first 4 days after initiation of symptoms, but adds additional information that the risk of transmission starts approximately 2 days before initiation of symptoms. So, and now the $1,000,000 question, can PCR predict risk of transmission? And the answer, like everything else in life, is yes or no. So let's see what's happening in PCR. So I'm sorry if I'm bringing here some technical aspects, but I thought it might be interesting for you to understand exactly where we're coming from and why PCR cannot always indicate the amount of virus, the result of PCR. So this is a schematic representation of the SARS-CoV-2 genome with the different open reading frames that gets transcribed and translated. And these double arrows indicate the sites where primers for PCR are located. So you can see that lots of places that people picked to amplify the virus, most of them in the nucleocapsid. What happens during the PCR? So the first step for this virus is the reverse transcription, which is not depicted in this cartoon. But after you reverse transcribe the viral RNA, you end up with a complementary DNA, which is shown here. And the first step of PCR is heating up the samples to open the double helix, which will then allow the primers to anneal to their template. And that happens in a step that's called annealing that has a designated temperature. And here is actually the crux of the problem. So if the primer is a perfect match for the template, so all these little teeth align perfectly, then a lot of primer will bind to the template and the amplification will be extremely effective. However, if there are misalignments, like a base pair doesn't match exactly, or 2 base pairs, or the GC content of the primers and the template is not optimal for the temperature at which the primer is supposed to be to anneal, less primer will bind to the template. And it doesn't sound like a lot if I say that, you may bind 1,000 primers versus 500 primers, but this difference of 500, when it's exponentially amplified down the road, can translate into 500,000 copies difference. So this is why the PCR a priori cannot be considered quantitative. You have to actually make it quantitative. And what happens, this is the way we resolve real-time PCRs. So what this graph shows is the threshold, which is also known as a crossing threshold. And these are DNA amplification curves. And when the DNA amplification crosses the threshold, then it's considered positive. The result is considered positive. And on the x-axis, you can see the cycle number. And the earlier in the cycle number the DNA crosses the threshold, the more virus there is in the sample. So there is some relationship between the crossing threshold, the cycle where the crossing threshold takes place, and the amount of virus. But this does not, this is not quantitative until you have a quantitative standard and a linear regression curve on which you can interpolate the result. Because look what happens here in real life. This graph shows the results of an experiment that was done by CAP. CAP stands for the College of American Pathologists. And what CAP did, they sent to multiple laboratories specimen that contained the same amount of virus and asked each laboratory to report the crossing thresholds of that they obtained by running the specimen on multiple FDA approved platforms. So each laboratory used one platform. Here on the x-axis, you can see the platforms, and you can probably recognize here Abbott, that it's used at Denver Health, GeneXpert, that it's used pretty much everywhere. We use a lot of Roche at university, and Thermo Fisher. And on the y-axis, you can see, and these are the numbers of laboratories that use each platform. And then on the y-axis, you can see the crossing threshold. So for the same specimen with exactly the same amount of virus, the crossing threshold went all the way from 20 copies per ml, from cycle number 20 for Abbott to cycle number approximately 35 for Luminex. So you cannot, based on this, you cannot estimate the amount of virus using the crossing threshold. I think it's pretty clear here. But to make it even more obvious, I put together this table from a study that's still available online only. And I selected some studies that specifically investigated the relationship between PCR and culture, with the idea of identifying a crossing threshold that may indicate infectivity. And here are 8 studies that I selected based on the fact that they had a reasonable number of samples tested with a reasonable number of positive results. And look at what happened here. So this column shows what is a threshold for no growth based on the crossing threshold. So it varied all the way from 24 to 35. Again, reproducing basically or confirming the results of the CAP experiment and showing that we can really not use crossing threshold as an indication of infectivity unless we know exactly what we're dealing with, unless there is a study that shows what this relationship is. And as an extra bonus, I brought you here also some information on the amount of virus that was needed to grow for a positive culture. These 2 studies looked at it, and it's basically, in both studies, it was approximately 6 to 7 million copies per ml were necessary for the culture to turn positive. So in summary, what I would like you to take, the take-home messages that I would like you to take from this is that PCR is currently the preferred test for diagnosis, hands down. And the time, at this point, the time after initiation of symptoms is the most reproducible criterion for estimating the risk of transmission. And with this, I'm gonna stop. I don't know, Karen and Sarah, if you want me to take questions now. I am due for a crown placement in approximately 40 minutes. So I'm not gonna be able to stay until the end of the discussion.
In that case, I would ask if anyone does have any questions, please quickly enter them into the chat box. I'm just going to ask what you think are reasonable uses of the antigen test given the limitations of sensitivity. Where do you think that's best applied?
Okay, so there are some studies that show, at least one study that's pretty good, that showed that if you use it frequently enough, it's better. So if you use a test twice a week, for example, to screen populations, screen groups, it's the likelihood of detecting positive individuals and stopping a chain of transmission is higher than if you use PCR less frequently, like every 2 weeks. But if you have the option, the possibility of using PCR every 2 weeks, then it's a lot, the results are much better. So it depends on what, so if you cannot screen everybody by PCR, then antigen detection is an option if it's done frequently enough. Also, the CDC has put out some guidance on how to interpret antigen detection tests, antigen detection results. Basically, the bottom line is, in people who are symptomatic and have a positive result, then you consider them infected. In people who are symptomatic and have a negative result, you have to run a PCR to figure out what's going on. And in people who are exposed, that's where I think I may not agree completely with the CDC, and Michelle knows that I don't always agree with the CDC. For example, at the beginning of the pandemic, when the CDC advised people not to use masks, I was very upset, and I asked Michelle, why are we doing this? But anyway, so I will let you decide on the latter part of the algorithm that's proposed by the CDC.
I'm also going to ask you, I think as clinicians, we're seeing more and more people that don't really follow our guidelines regarding not retesting within a certain interval. And then the question is always, what do we do with these individuals? Is there good data on the average time to continued shedding for individuals that are not immunocompromised?
So I think that for the individuals that are not immunocompromised, what you're interested in is transmission, I think the data are pretty clear that after 10 days, you really don't have virus to transmit. And even if you have a positive PCR, that virus may be coated with antibodies, for example, and that's going to decrease the ability of the virus to infect the new cells, or that virus may not be intact. There are many defective particles. So in an immune competent host, I would go with 9 to 10 days, and then it's done. Now, in an immune compromised host, things are completely different. And then I think that you really need, the best thing that you can do at this point is to have 2 negative PCR results. And then how long can these people shed? They can shed a long time. There are studies like you shared with me that, it was 40 days. There are studies that show shedding for 60 days. In non-immune compromised hosts, the CDC defines reinfection when there was at least 1 month interval between the last positive result and the new positive result. I'm not sure what's that based on, but it's some way to go by. I guess we don't know how much reinfection there is around.
Thank you so much. We had a comment from Corbin. I don't know if you want to unmute and say your comment or talk about it.
Sure. Can you hear me?
Yes.
Hi. So I am a infection control nurse here in Pueblo, and I've been working really closely with PDPHE and CDPHE actually, and we were encouraged for the longest time to withhold from using our antigen POC testing because There was a 40% false positive rate and a 20% false negative rate. So what's the rationale between us continuing to encourage using the POC testing versus just sticking with the PCR?
So what you mean by POC is antigen detection, because there are also PCR tests that are POC. But you mean antigen.
POC antigen, yes.
Antigen. So I don't know where CDPHE got the data on the 40% you said false positive results. That's
Yes.
not I'm not aware of any studies showing this. I think there is a risk of false positive results if the test is done correctly. So again, it's very important to do the test according to the manufacturing instructions. The risk of false positive results is very low, very low. So there was a large study that the CDC performed that it was presented at one of the CDC laboratory meetings. It's not published yet, so I cannot show you slides from that presentation. It was very carefully done, and the specificity of the test was really higher than 95%, or around 95%. The sensitivity of the antigen detection test is lower. So it's more like 80%. And I showed you why, because the antigen detection test requires a lot more virus than PCR. So why would you use it? So you would use it, in a patient who is symptomatic, or in a patient who was exposed and has a positive result. That's the end of the story. Yeah. Now, if the test is negative, then you have to, I think that the wise thing is to follow up with a PCR.
So originally we had used our antigen testing because on the opposite side of the building, we had residents test positive for PCR. And actually they had tested PCR positive with the state, but they had been retested with 2 different private labs, PCR, and they tested negative. We had 14 positive POC antigen testing, but when following up with 2 more PCR testing, they were negative.
As I showed you in my slide about the lower limit of detection, not all PCRs are made equal. And the PCR, so for example, off the top of my head, but I think it's pretty accurate. The CDC PCR test has a limit of detection of 150,000 copies per ml. The Cepheid, the gene expert, has a limit of detection of around 100 copies per ml. So you have 2 orders of magnitude there. So it's easy to understand why one specimen may result positive with one method and negative with another method. Now, what happened, why there was a discrepancy between the antigen detection antigen and PCR, whereby the antigen was positive and the PCR was negative, I cannot comment without knowing more details on how the antigen test was performed, how the PCR was performed, if it was performed on the same specimen, if 2 specimens, how were the specimens collected, if it was on the same specimen, how was the specimen preserved between one test and the other, because RNA is labile, there are lots of RNases. If you don't keep the specimen refrigerated or frozen, the RNA will degrade and so on. So there are many details that you need to control when you do, and that's best done in the ambit of a study rather than with anecdotal information, because there are all these issues with anecdotal information that you cannot control. Whereas in a study, you have a protocol, you know exactly what you're doing and how you're comparing the 2 tests.
Thanks.
Awesome. Well, thank you.
You're welcome.
Thank you so much. And thank you for asking your question, Corbin. Dr. Amy Meditz, you had a question you wanted to ask Adriana before she runs off for her crown?
I'd rather stay here. I'm telling
Yeah.
you.
Hey, Dr. Weinberg, nice to see you. I'm curious, can the PCR test be positive with partial pieces of the virus? So does that count in the total cutoff?
Yes. Yes.
That was my understanding, but I started to doubt myself when I was listening to you. So, okay.
You are very, yeah, I don't know why, I don't know what I said that made you doubt, but yes, the PCR doesn't need a complete genome, complete virus, complete anything.
So what I guess was giving me concern was that people were talking about trying to have 2 negative tests, and outside of immune compromised hosts, severely immune compromised hosts, we've kind of moved away from that, and just with people that are slightly immune compromised or very sick use the 20-day cutoff, and then people who are healthier, outpatients, just using the 10-day cutoff.
So I think it's your judgment, Amy. I think the data are pretty good, are very good for the immune competent hosts with middle of the run infection with 10 days. When you go to immune compromised hosts, I'm not aware of any good studies that will let me say this is what's appropriate. And then when personally, and that's my personal approach, when I don't know what's appropriate, I tend to err on the side of being safe rather than adventurous.
And do we have a definite definition of what immune compromised means? Like, my 90-year-old guy that has heart disease that had bad illness due to SARS-CoV, is that immune compromised, or are we saying you have to be on methotrexate or, actual medicine?
Immune compromised for me is somebody who has AIDS, who has is post-transplant, who is on some kind of goodly amount of immunosuppressive medication, or has some other type of known immune deficiency.
What about pregnancy?
So pregnancy, it's very interesting. I think that pregnancy is did not bear to be a risk factor for severe disease. What happens with pregnancy? No, pregnancy, I would not consider these patients at higher risk of transmitting the virus. What happened with pregnancy is the reason why they are considered high risk, it's because there are all sorts of mechanical problems with ventilation and such, including the high level of progesterone, which is a vasodilator. And so there are physiologic characteristics of pregnancy other than immunologic characteristics that makes these people more likely to require respiratory support and ICU if they develop severe disease. But the risk of developing severe disease is not higher than in non-pregnant adults. And actually there are some studies that indicate that the risk of developing severe disease in pregnant women is lower than in non-pregnant adults. Did I confuse you completely?
Fantastic answer. Thank you.
Welcome.
And Sarah, did you want to unmute and ask your question?
Sure. Thanks for the presentation. Aside from viral culture, are there some viral targets that we could look for that would be evidence of a replication competent virus?
So not that I know of. So right now, there is nothing that will tell you binucleic acid detection if the virus is replication competent. And again, as I mentioned, these viruses that come out of the patient, they may come out coated with antibodies with their membranes broken, such that even though you have a lot of RNA, this virus is not in its best condition to infect someone else. Okay, now I really have to go to my dentist. I'm sorry.
Thank you, Dr. Weinberg. What a great presentation, and thank you for answering all those questions.
Bye-bye.
Bye-bye. And so now we are fortunate to have Dr. Michelle Barron joining us, who is the Senior Medical Director at UC Health, Infection Control and Prevention. She will discuss clinical considerations for removal of transmission precautions, which I think we had a good lead into. Michelle, go ahead and take it away, and thank you so much for coming today.
Yeah, thank you. Let me get my, all right, so before we get into really the specifics of the transmission precautions, I want to just make sure we talk about the modes of transmission, because I think that there certainly is a lot of data and a lot of controversy to some degree on this. So definitions, everybody knows what a respiratory droplet is. It's greater than 5 to 10 micrometers in diameter. If you're less than 5 micrometers in diameter, it's a droplet nuclei or an aerosol. Droplet transmission occurs in close contact. The 6 feet rule is really just based on studies in which people cough or sneeze, and then being able to measure the distance of how far these droplets can actually travel. Certainly this can occur with coughing and sneezing, or if you're talking or singing. If you're in close range, these droplets can then potentially land on you. Certainly anyone with children has had this occur. And they can also obviously land on surfaces, and then there is a component where you could have contact, but that tends to be less often that it occurs. This is in contrast to airborne transmission, in which there is a suspension over time and distance of the droplet nuclei. And we are very familiar with droplet transmission. Influenza, most of the respiratory viruses all fall under the droplet transmission. Airborne, TB is probably the one we're most familiar with, but measles is another one that would be of concern. The primary mode of SARS-CoV-2, which causes COVID-19, is droplet. There are this ongoing debate about aerosols and the component of aerosols and whether or not aerosols are a primary mode of spread. It is not a primary mode of spread in general. It can potentially occur under circumstances in which you have confined spaces over long periods of time with poor air exchange. However, a lot of the data that suggests this type of mode has been really in the lab in terms of like real life, in terms of being able to prove the mode of transmission. There's certainly some data to suggest it, but there's nothing at this point that is certainly shown to be definitive. Why are you not? Here we go. These are some studies I think that are important to be aware of. This is somewhat talking just about masks and the importance of masking. There was over the summer 2 hairdressers in Missouri at a Supercuts that were both diagnosed with COVID-19, and it inadvertently exposed about 100 people that had had up close and personal contact with the individuals while they were having their haircut. About 60 of these individuals, all of them were tracked for symptoms over the 2-week period following the exposure. And about 60 of them actually had viral testing during that time frame as well. It's important to know that obviously, as Adriana already alluded, that not all testing is perfect in terms of whether or not if somebody has symptoms, it's more sensitive than if they have no symptoms. But that being said, over the 14-day period, none of the individuals that had contact with these individuals developed symptoms, and none of them tested positive on PCR. Importantly, the 2 individuals were wearing masks. So even though the individuals that they were cutting hair did not necessarily wear masks, the presence of a mask did seem to have an impact in terms of the potential for the transmission. The next study that was published in early June, and there's been subsequent studies that have looked at this. Again, the sample size is not that high, but it's still interesting to look at. 41 healthcare workers that were involved in a stat C-section that required the individual to be intubated. So they were all in the room within 6 feet and more than 10 minutes during the intubation process. Most of them were wearing surgical masks, not N95s, because at the time, the degree of positivity amongst patients that were delivering babies was not thought to be high. All of these individuals were PCR tested at baseline as well as at day 14. None developed symptoms and all tested PCR negative. This goes back probably to the degree of what Adriana had talked about already in terms of the individual happened to be asymptomatic, and there's probably some degree of difference between asymptomatic viral shedding and degrees, how the quantity of virus and the impact on that. But again, masks work. The last one I want to mention, only because I think this was initially sort of touted as, oh, proves to you that airborne transmission occurs. And this was a choir practice that occurred in the state of Washington. It was a 2.5-hour choir practice at an old church. 61 individuals were there, including an individual that was having active symptoms. There's a pretty high attack rate at this, 32 confirmed and 20 probable cases. So almost everyone there ended up being infected. Transmission likely was facilitated by close proximity during practice. All of them were in close proximity to each other when they were singing. There was probably a component of air handling in that it was an old church, and so there wasn't necessarily a lot of air exchanges. And the fact that all of them were singing probably also contributed to the fact that there was spread. There may again have been a component of airborne to this. However, there's still a lot of, I certainly have a little bit of skepticism just because of the amount of proximity to all the individuals that were there, but this was certainly considered a super spreader event just on the basis of how many people that were exposed and subsequently became ill or tested positive. So in terms of PPE, the current standard for universal precautions, everybody knows that, is that you wear appropriate PPE based on the risk of potential transmission. At the present time, it is recommended that everyone must wear a minimum in patient care areas, a medical grade or surgical procedural mask. And with the high rates of transmission in the community at present, eye protection is also recommended. If somebody is known or suspected to have COVID-19, at the University of Colorado Hospital and the UC Health System, we actually have two different ways of how we base our transmission-based precautions. We have what's called enhanced droplet precautions and enhanced airborne precautions, and I'll talk about those in just a second. In non-patient areas, here again at the university, everybody is still supposed to wear masks, whether they're medical grade or cloth, and they're required if you cannot maintain a minimum of 6 feet between individuals. Certainly in clinic areas, everybody's wearing surgical masks. This applies more so for like areas that are more the business or administrative areas of our hospitals, and where they are either not able to telework or there's not enough distances between their cubicles. This is an example of the signage that we use for this, and really the difference is the type of mask that we use for the two of them. All of them require that you do hand hygiene, you wear gown and gloves, you wear your eye protection. For enhanced airborne precautions, an N95 or equivalent respirator, which could include a half-piece respirator or a PAPR, are used, where in enhanced droplet precautions, a surgical mask is used in lieu of the respirator. In both instances, the preference for a room selection is a negative airflow pressure if available. However, it is not a requirement. What are aerosol generating procedures? And that's really the distinction of how we decide between when do you do airborne and when do you do droplet. Aerosol generating procedures, there's not a lot of data on this. When you look in the CDC, they give some example of this. When you look at some of the papers that this is based on, again, some of them make sense. Some of them it's sort of maybe soft in terms of the potential for aerosol generation, but it's what we have. And again, you can see listed here, intubation is and extubation obviously are some in which we would expect some aerosol generations. Positive pressure ventilation as well, or high frequency ventilation, and then other things like pulmonary tests and bronchoscopy and endoscopy. this again, just sort of, this should have preceded that, so forgive me for the order. But this is again, enhanced droplet precautions, and this is for suspected or confirmed COVID-19 patients. And this is with the assumption that for all of the other patients that are not suspected or COVID positive, that you're wearing a minimum of a mask as well as a surgical grade mask or eye protection. Negative pressure room, I'm going to talk about you always want to keep the door closed if the pressure in the room is negative or it alarms. If it's not set up for an alarm, leaving the door open obviously this keeps the negative pressure from not doing its job. I'm going to skip this one. The one thing I want to point out in terms of the half mask respirators, which we use quite a bit, especially in our COVID units here, is that there is an exhalation valve. And so if somebody's performing a procedure that requires sterility, either you want to make sure that you use a different type of mask at that time, or you want to put something to cover the mask so that it doesn't actually have that potential exhalation right onto your sterile field. This is one of the flow diagrams that we use. And again, it just sort of walks people through the different types of precautions, enhanced airborne or enhanced droplet. And again, as we've found with COVID-19 that you have to have all sorts of charts and all sorts of different ways for people to learn, because sometimes the written document isn't as obvious as a flow chart. Sometimes the flow chart is not very obvious. And so we've really tried hard to have different ways of presenting the same type of information so that the information is clear. And even then, I feel like it's not always clear to everyone. Room turnover is something that comes up a lot in terms of how long does a room need to be closed after somebody's had a procedure, aerosol generating procedure, or if you have a COVID positive patient, how long after they've left the room or been after discharge or otherwise before the room is considered clear. Most of this really depends on the air exchanges in your particular area. And this is where your engineering group or your facilities group is really important in that they can actually do testing for the most part and tell you how many air exchanges occur. And this is a table from the CDC that actually looks at the air changes per hour and the time required for the airborne contaminant removal by efficiency. It's broken into 99% versus 99.9%. The CDC does say that 99% efficiency is sufficient for patients with COVID-19. And so that's the table that you would look at. Most exam rooms are about 6 air changes. Your ORs are about 20. Pretty routinely. And this is irrespective of whether or not the pressure is negative versus positive or neutral, which is what most of them are. Negative pressure implies that the air, when it is actually goes out of the system, goes outside, versus positive, which is where you're usually is used in bone marrow transplant units or other type of protective units, which is using the air exchanges and the air filtration system to prevent particles from going in there. And again, most of the most rooms in hospitals and exam rooms are slightly positive or tend to be neutral. And so you can see that this impacts potentially if you have clinic patients that are being seen in terms of room turnover, the amount of time in which it needs, if average is about 6 air exchanges per hour, you can potentially have a room down for a long period of time. And this is one of the things that we think about in our emergency departments in terms of where we place patients that are potentially suspected for COVID-19 or where our aerosol generating procedures are being done. 2 definitions I want to make sure we're very clear on because it impacts how we think about when we stop our transmission-based precautions: quarantine and isolation. Quarantine is used for individuals that have had exposure to someone with suspected or confirmed COVID-19. And isolation is used for individuals that have actually been diagnosed either clinically or have a positive test. The CDC just changed their recommendations literally a couple of days ago regarding duration of quarantine. And they now have it used to be that if you were exposed, it was 14 days from date of last exposure, and that was considered the time frame in which quarantine had to occur. It now has that if you are asymptomatic and you test between day 5 and 7, and the test is negative, and again, asymptomatic, you can end quarantine at day 7. There's still a minimum of 7 days required for quarantine, but this includes the testing caveat. If you do not get tested, then the minimum amount of quarantine is 10 days, and then they can remove themselves and be able to go back to their normal activities. The presumption on all of this is that individuals remain asymptomatic. And if they do develop symptoms, then obviously you have to actually have testing done. And the testing done earlier than the 5 to 7 range does not shorten the duration of the quarantine. And you still have to do it sort of later stage. And that has to do a lot with just the incubation period after exposure and development of symptoms, which on average is between 5 and 7 days. As I mentioned, isolation is when you actually have a suspected or confirmed case of COVID-19. If you're immunocompetent, Adriana already set the stage for this in terms of duration of viral shedding that can potentially last with transmission. And so 10 days from either symptom onset or 10 days from a positive test if they're asymptomatic. If they're immunocompromised or have, quote, severe disease, so these are usually hospitalized patients that require steroids and treatment. The duration of isolation is 20 days if asymptomatic, or 20 days from the positive test if they were asymptomatic. There also is the caveat for both of these conditions that they would have improvement in their symptoms. Taste and smell can delay, so it's really the respiratory symptoms that they look at in terms of measure of improvements, and they cannot have fevers for at least 24 hours without antipyretics. So when do you remove this? The CDC has some guidance on this specifically. They had previously recommended test-based approaches where you had to have 2 tests 24 hours apart. And then because of the factors of consistent shedding of virus that was unlikely to actually result in transmission, they now base it on a time-based approach. And the time-based approach to clearance of transmission precautions matches almost exactly what we do with isolation. So 10 days if you're 10 days if you're immunocompetent, 20 days if you're immunocompromised. There is some data now that suggests that not all immunocompromised patients are alike, which we know. This makes sense in terms of the degrees of immunosuppression. Specifically in hematologic malignancies and transplant patients, there's some studies that are, there was a study just published in the New England Journal of Medicine as a letter to the editor with the experience at Sloan Kettering, where they evaluated not a huge sample size, but transplant patients, hematologic malignancy patients that had stem cell transplants or CAR T therapy. And we're able to show that these individuals, even after 20 days, potentially, some of them up to 50 and 60 days, were not only still shedding virus, but had replication competent virus that in the way they measure this in cell culture, potentially had the risk of transmission from their shedding. So with that in mind, we generally will follow our rules in terms of the 10 or 20 days for our patients, and in stem cell transplant or solid organ transplant, where there isn't as much data, but still the similar concern in terms of the level of immunosuppression, we are still recommending that they get 2 PCR tests at least 24 hours apart and be negative, with all the other caveats of greater than 20 days before we do the test and have to be clinically improving. It's not perfect in that you can still have some mismatches where somebody will test positive one day and test negative the other day. And I think Dr. Weinberg talked a lot about some of the issues with why that can happen in terms of sample collection or potential for the threshold of detection, but it's as good as we have at the moment. This is the data on which the viral shedding days of comparing the viral RNA and the infectious virus, and this is one of the papers that the CDC used. The light gray bar, which you can see, is if you can see it in these cases, is the infectious virus versus the quantity of PCR. And this goes back to the question of viral thresholds in terms of what is the amount of virus you need to actually have transmission. And in the upper level in A, you can see that 10 to the 5th was the amount of virus that was detected on PCR and did not seem to correlate with infectious virus. And when you start getting up into the 10th to the 9th, you can see that there is more replication competent virus that's considered infectious. But on average, most individuals, and this lower bar, the gray dotted line is the threshold for transmission. Most individuals will fall in that range for about 10 days. And again, in immunocompromised hosts, which is in a separate paper, most of them are actually about 15 days, but it can go out to 20 days. And this is where those cutoffs for when you can stop isolation and remove transmission-based precautions is based on. So I will stop there.
Thank you so much for that great talk, Michelle. And I want to just introduce that we have another person that we're going to include in our panel today to discuss questions. And I thank you very much for coming today. Shannon O'Brien is one of our guests who is a medical epidemiologist at Colorado Department of Public Health and Environment. And so I'm going to go ahead and open it up for questions, and feel free to unmute. I did see a couple in the chat box. Corbin, do you want to unmute and ask yours?
Yes, back again. Would you define nebulizer or the use of nebulizers as a aerosolizing event?
So yes and no. So you do obviously do some aerosolization with the nebulizer, but you're actually aerosolizing the medication. You're not necessarily aerosolizing from the patient's standpoint. So this has been one of those controversies, I think, that comes up. We get a lot of questions about it. And when you look in the literature, they sort of specify that you're aerosolizing the, now, could you have them cough? And does that count as aerosolization? I think there's still ongoing debate with that, but we do not treat it as an AGP in our institution, but there may be some variability regarding that across other hospitals.
Perfect, thank you.
I guess, can I follow up on that question about what's aerosolizing? So you mentioned in the emergency department some implications for PUIs. And so what are your guidelines if you do a nasopharyngeal swab in the emergency department?
So in those rooms, we've actually, for the ones to try and keep flow in the emergency department, which is obviously an essential part of them, some of the rooms we've installed HEPA filtration systems really to just increase the amount of air exchanges in the rooms so that the downtime isn't as long as 45 minutes. So we've been, our engineers, they are our godsend in our hospital right now in terms of what they've been able to do with our air handling systems and either making some areas negative that weren't negative before, and then increasing air exchanges either through having filtration devices or just jimmy-rigging what they do. So that's really what we've been doing, is just for those areas that are kind of critical in terms of not being able to have a room shut down for a long period of time. They sort of have augmented the amount of air exchanges in those rooms, usually with portable devices or engineering ways that I don't really understand, but work.
And then Dr. DeGroot, you had a message in the chat. Do you want to unmute?
Hey, Michelle, thanks a lot. I haven't worn one of those half masks and I don't really understand them, but you mentioned there's an exhalation port, and I get that you want to cover it to protect your surgical field sterility, but if you were asymptomatic shedder of SARS-CoV-2, tell me about that.
Yeah, so it's again a theoretical risk that you could be potentially the same way, and not just your surgical field, but for people that you're around. So we actually do not recommend people run around with their half-face respirators. They're the ones that look like the Darth Vader mask, for those of you that aren't familiar with it. We have them used in rooms with patients that are suspected or confirmed with COVID-19, and we have enough air exchanges and everybody's wearing protection. So there's no risk, everybody's in the proper PPE. But outside of those patient care areas, they're supposed to wear their surgical masks as their normal protection, or their N95, depending on what their what they're doing or where they're located.
Perfect. Thanks, Michelle.
And then Erica Gleep, I'm sorry, I'm not going to get your last name right. Do you want to unmute and ask your question?
Sure, it's Gail Gand, by the way. So I just got off of EFS 8, that's a toughie. And CDHPE is recommending that Chaffey County now use the BioNex Now antigen test for schools and to release kids to go back to school. I understand that the positive is positive and great, but what about the negatives? And with the first speaker says you should follow up with a PCR. Is there really, I mean, is this really a good way to go about this? Give people a false sense of security? And is it something that one could use in a hospital setting for employees?
Yeah, so, I think that's a great question. And we actually have school specific guidance that states, and I can put it in the chat, like go find it and add it to the chat. But some of the tools are called return to learn tools, and they actually state in there the testing requirements for ill individuals, be it students or staff, to return to the school setting. And it actually explicitly states which types of tests can be taken essentially kind of at face value, be it positive or negative. And when it comes to the point of care antigen tests, we take a positive, as kind of was discussed previously. The positives we believe, especially in a symptomatic individual, so those we take at face value. But as you mentioned, because of concerns for false negatives, a negative point of care antigen test would need to be confirmed with a kind of test with a higher or better test characteristics such as PCR. And so I think, something that I've been saying and was kind of alluded to previously is the idea of the antigen test sort of becomes a net for catching positives. And so we're really just trying to catch as many positives as we can. And so in some settings, that would mean you're testing a certain group of people, on a more routine cadence, maybe a couple times a week. Some places they're even doing it daily on, say, staff, like you mentioned. And that really improves the test sensitivity. Or in some cases, it's a situation where maybe you don't have a lot of better opportunities for testing. And so this is kind of the best test that you have, and you try and figure out sort of the best use case in that scenario. So, it's definitely, you have to weigh the pros and cons. And if you do ever find yourself in a situation where you're trying to figure out what's the best way to use these tests or anything like that, do feel free to reach out to us. And I'll put my email in the chat, and happy to kind of help people work on any testing paradigms or strategies that they're looking at.
Thank you.
And one other thing that I did just want to mention, because Michelle did bring up the new quarantine kind of options from CDC. We are, I think, hopefully going to have our CDPHE guidance official today, I hope. But we are planning to implement the new CDC guidance, but there will be some kind of nuances. And, one thing that I want to kind of reiterate that I think is important and sometimes gets lost in the excitement over new shortened quarantine is that the CDC recommendation does still remain at 14 days. And these are kind of considered options based on some modeling data that they have. And so the way that we're anticipating it's going to be operationalized in Colorado is that most people will be able to utilize the shortened quarantine period, but we recommend for people who either are or work with or live in high-risk settings that they would still stick with the 14-day quarantine. So that's going to be people who are living or working in congregate settings. I think in a lot of healthcare settings right now, because we have staffing shortages, it may not really look differently right now. But, in best practice, we would want healthcare workers, long-term care facility workers, things like that, to still be utilizing the 14-day quarantine period. So hopefully that'll be finalized today, but just wanted to put that out there.
Great information. So I think we are just a little bit over time. I want to thank our fabulous speakers, and definitely thank you, Michelle, for that wonderful talk. And thank you, Shannon, for joining us and answering questions and providing us some insight on where CDPHE is and what to look out for later today. So thank you so much. We'll see you all again in 2 weeks, and take care of yourselves and stay healthy.
We'll see you next week for that because of the holidays.
Oh, okay. Thanks.